I'd like to welcome everyone here tonight to, well, someone can help me. I forgot to look. Is this the 14th, 15th, 16th, or 17th Hager lecture? I should know that. It's been sitting on the screen, but we want to invite you all tonight. This is really great to see so many from our community, our faculty, our alumni, our students, but then so many from other communities within the university and within the community. I want to welcome Dr. and President Jerry Clancy from OU Tulsa. I know that there are lots of students from the nursing school here. I know that there are folks from OSU here. And I guess I just want to say that this really underscores in a very important way how interdisciplinary, by definition, the law is, and also how much it is my hope and our hope as a law school to partner with lots of different institutions and groups in the community to help further important issues of social change and social justice. I think at the end of the day we are doing our job if we do that. John Hager, I did not know John Hager, but many of my colleagues in the room did know him very well. He was a beloved professor of torts. Now, I hope that doesn't scare all the doctors here away, but he was known as the king of torts, and he passed away much earlier than many of us would hope, and his friends and family very generously in this lecture, which is one of 3 endowed lectures we have at the law school, but this is by far the most prominent lecture that we have. From what I have heard and learned of John Hager, he was a brilliant torts professor. He was thought a lot about issues of social justice and ethics, but he was also a tremendous teacher. He was known to just be also a tremendous teacher. And so tonight, I am actually going to pass the podium to one of my colleagues, Matt Lampkin, who was a student of our speaker this evening, and who not only was a student, but it's my understanding that Professor Elliott really sparked in Matt Lampkin and Professor Lampkin the seeds of what has grown into just a really productive career, early career, but productive career in health law and health ethics. And Matt is one of 4 faculty that joined us this fall, and so I'm really honored to ask him to come up to do the formal introduction.
Thanks. I think if there's a cardinal rule about introducing someone else, it probably should be don't make it about yourself. But I'm going to violate that briefly, very briefly, because as Janet mentioned, I wouldn't be here tonight if it were not for tonight's speaker. I was reading his book that prompted me to leave my legal practice and pursue scholarship in law and medicine. And it was his subsequent generosity in the ensuing years that enabled me to realize that dream and to get to work at a great law school like this and to get to do what I love every day. So I think I'm obligated by custom to describe Carl's credentials, which of course are very impressive. He's a professor of bioethics at the University of Minnesota. He has both an MD and a PhD in philosophy. He is the author or editor of 7 books, has been a fellow at Harvard's SAFRA Center for Ethics, an assistant professor at a visiting associate professor at the Institute for Advanced Studies, Princeton. But more important than that, I think, is the fact that he is a deeply unpopular man. in certain circles. And that is because rather than using those credentials to feather his own nest, he has used them to fight doggedly against the exploitation of vulnerable people and to fight corruption in the medical industry. So, for example, he has been a vocal critic of bioethicists who take money from the very entities whom they are supposed to be policing, which has made him unpopular there, and has tirelessly fought to keep a horrific abuse of a research subject at the University of Minnesota, his own institution, in the spotlight and hold people accountable there. None of that has made him very popular with the people who stand to profit from keeping these kinds of things in the shadows. But I am deeply grateful that he continues to fight those battles and extremely privileged to get to introduce him here tonight. So please join me in welcoming Carl.
Well, thanks. I can't. There's been some kind of mistake in my being here. I don't think I've ever given a lectureship like this in a law school before, and I'm still a little puzzled as to why I'm actually here. And that's why I think it may have been a mistake. But I'm very grateful to be here, and I just want to say that I know nothing about the law. Never taught a course in law. I don't think I've ever even been invited to give a talk in the law school at the University of Minnesota. And so if you ask me any questions about the law, I'm going to refer them to Matt to answer. I do have some students who are lawyers, fortunately for me. Also, I'm very grateful to have been here, and everyone has been incredibly gracious to me, and I do appreciate that. I have to say I especially appreciated waking up this morning and looking out the window at the Woody Guthrie Museum and seeing this big mural of Woody Guthrie with his guitar that says, "This machine kills fascists." I need that guitar. So let me just start right in here. So a few months ago, I was inside this building right here, which is actually a homeless shelter in central Philadelphia, and I'm sitting across a table from a guy who is explaining to me how he wound up in the Ancora Psychiatric Hospital in New Jersey. And he says to me, well, I sprayed myself with a fire extinguisher, and they strapped me to a gurney, and an ambulance took me to Ancora. And so I said, and I realize this is not the most intelligent question, but I said, why did you spray yourself with a fire extinguisher? And he said, I don't know, just grabbed it off the wall. And so the reason I was sitting there talking to this guy, who I'm going to call Anthony, he doesn't want his real name out there. The reason I'm sitting there in this shelter talking to Anthony is to figure out how this friendly, extremely talkative homeless guy with a diagnosis of schizophrenia has wound up in 22 separate research studies of experimental antipsychotic drugs. Only do schizophrenia studies, he tells me. They call me a professional. And even though he's kind of laughing when he says that word professional, the fact is it's not really that far from the truth. The fact is he does these studies because he's paid to do these studies. Tells me the most he's ever gotten paid for a study is $4,000. Most of them pay a lot less. $4,000 is not bad if you're living in a shelter. He says he tries to get into the studies for severe patients, but he doesn't qualify because you need to hear voices every day for those, and he only hears voices once or twice a month. Now, if you're wondering whether Anthony's unusual, He's not, really. If he's unusual, it's only because of the sheer number of studies he's done. 22 is a lot of studies, one of these guys. But if you go to any place in Philadelphia where homeless people are gathered, like the Parkway, the Benjamin Franklin Parkway here, or this place, the Chosen 300, this is a mission, sort of storefront church mission that serves meals to homeless people. If you go to any of these places in Philly, you will find a lot of destitute people with mental illnesses, most of them black, who've done drug studies in exchange for a paycheck. And the explanation for that is pretty simple. If you want to test drugs for mental illnesses, you need mentally ill people, and the shelters are full of these people. So I've been going to Philadelphia. I've been for the past 2 years, I've been there 4 times over the past 2 years, talking to homeless people about these studies. And one of the shelters I go to is, this one is called the Sunday Breakfast Association shelter. And last fall, I sat down inside with a guy named George, very smart guy, easy to talk to, sort of this ironic way about him. Shaved head, sort of wispy goatee, this David Letterman-like gap between his front teeth. And I'm enjoying the conversation so much. He's so funny and so smart that I'm a little shocked when he tells me that he's been in prison, that he's been on a lot of psych meds, and that he's tried to kill himself. I had seen a recruitment flyer out front, took a picture of it. It was a flyer seeking people with cocaine dependencies for research studies. And I asked him about that, and he just nods and says, you know, the fact is a lot of people start taking drugs just so they can get into those studies. You start taking it, get it in your system for 2 days, and then you can pass the screening. He said he'd interviewed for a psych study, and the waiting room was just filled with these people. High as a kite, he said. They were incoherent. And it turns out that at this particular shelter, at Sunday breakfast, the recruiters will park outside on the sidewalk right here and approach people. Approach the residents to recruit them. Talked to a vet, a homeless vet, I'll call him Ed. He told me how it worked for him. He and his wife have been on the street for about 2 years. His wife's pregnant. He's got bipolar disorder and depression. Says they're in a shelter when he gets a message. Message says, somebody from the VA is here for you. So he goes downstairs, goes outside, and when he gets there, there's nobody from the VA. But what there is a drug study recruiter. And he says, you know, I was tired, I was hungry, half an hour earlier, the police had treated us like crap, and this woman is saying, imagine, in 40 days you'll have $4,000. Says she made taking experimental drugs sound like a vacation in a 5-star resort. Now, if you're surprised to find out that drugs are being tested on mentally ill homeless people, you shouldn't be. I've seen it in Philadelphia, I've seen it in LA, and I imagine if I had the resources to go to other cities and dig around there, I'd probably find the same thing there as well. So what I want to do tonight is try to explain why. I want to explain how we got to the place where this is happening. I want to try to explain the forces that led us here and how, as bad as this might sound starting out, it's actually even worse. So let me just start with that. So I think when most people think of drug research, they think of places like this, like the Mayo or Harvard or Hopkins or another of the elite medical centers. The reality is actually somewhat different. Starting in the early 90s, drug companies started outsourcing their clinical trials. They started outsourcing them to private contract research organizations, contract researchers. You know, at the top of the heap of the contract research industry, you have large multinational companies with names like Quintiles, or Covance or PPD. And at the bottom, you have places like this, Mana Research in Toronto, which are very small trial sites, often located in office parks or strip malls. Contract research is a huge industry now, by some estimates up to $105 billion a year. Now, if you've never actually been to one of these sites or talked to the people who run them, it can be a little tough to imagine what they are like. So, fortunately, I have something that will give you a bit of a clue here. A couple of video clips. Now, these video clips are produced by a trial site in Southern California called South Coast Clinical Trials. And I'm going to show them to you. Together, they last, I think, about 4 minutes. So have to be patient. I don't want to ruin it for you. Here's what I want to tell you. This is South Coast is a trial site that specializes in psychiatric drugs. And the video clips are promotional videos for the site. So I've been out to visit South Coast, but I didn't film these. These are things that they filmed themselves and then put on the web in order to bring business into their site. Just to emphasize once again, these are promotional videos for the trial site. So the idea is that they film these themselves, they put them out on the web with the hope that drug companies will see these and decide that looks like a really good place to do a clinical trial. And it's thriving, so apparently that strategy is working. Now, I wouldn't want to claim that that is representative of private trial sites, but I also don't want to say that it's unusual. In fact, some people that I talked to out in Orange County said that South Coast was the best trial site in the area. And in fact, the others out in Orange County were much worse. So the basic idea I'm trying to get across to you by showing you that video is we're not exactly talking about a brain trust here, right? This is not where you're going to find your future Nobel Prize winners. This is a business. It's a business, but it is also an essentially unregulated business. And by that I mean there's very little oversight. We have our federal Office of Human Research Protection, of course, but it doesn't concern itself with private trials. It's only for federally funded trials. We have the FDA. The FDA inspects about 1% of clinical trials. So 99% of those go uninspected. That leaves IRBs, Institutional Review Boards, what in some other countries are called research ethics boards or research ethics committees. But in the private sector, IRBs are businesses too. They're a for-profit enterprise. What for-profit IRBs do is review studies in exchange for a fee from the sponsor. So you pay the IRB, it evaluates your study. It's a fee-for-service industry. If you don't like the answer, you can just take it to another IRB. Fee-for-service is also the norm for subjects. For a long time, it was seen as kind of ethically dubious to pay people to take experimental drugs. And the reason it was seen as ethically dubious was that it was thought that if you give people money, they might be tempted to risk their health simply because they were so desperate for the money and sign up for studies that are dangerous. So until recently, the only payments of any real size went to one group, the normals, or the healthy volunteers, right, who were mainly paid to do phase 1 trials. What are phase 1 trials? Some of you know, others may not know. Phase 1 trials are safety trials. So phase 1 trials are done right at the beginning of drug development. And the basic idea is to see whether a drug is safe or whether it's dangerous. And so what you need are people who will check into one of these research sites for weeks at a time. That means people who don't have a regular job, people who are willing to take untested drugs, people who are willing to submit themselves to all of the invasive procedures, all the blood draws, the urine collections, everything that goes along with doing one of these studies. And the fact is, very few people are willing to do that unless they come out with a paycheck at the end. What's happened is, as the studies have moved out of universities and into the private sector, we started to see a couple of changes in the payment. One, we've seen a change in the size of the payments, which are getting bigger and bigger. It's not unusual now to see trials paying $6,000 or $7,000 per study. And the second thing has changed is the range of subjects getting paid. So it's not just healthy subjects anymore. Now you're also seeing payments go to sick people. So asthma, kidney disease, diabetes, cancer studies, and of course, mental illness. This is a study in St. Louis offering $2,800. This is one in California offering $4,500. This is a study in Philly. And if you look at these, the operative word, the word that you should notice, is the word schizophrenia, because that word will tell you something crucial about the nature of the drugs being tested, which is what I want to talk a little bit about next. So I'm not an anthropologist, I'm not an ethnographer, I'm not even a trained reporter, and so my interviewing techniques are kind of crude. Basically, I just walk up to homeless shelters, ask around at the guys who are sitting around on the steps outside and say, hey, have any of you ever done a drug study for money? That's my technique. And that's how I met a guy sitting on the steps near the station house shelter here, on these steps, he's not in this picture, who said, yeah. His name was Sherman, big guy, very polite, educated, his first time in a shelter, in fact. Remember, the odd thing that struck me about him was he was dressed entirely in black and white pants, black and white shirt, black and white shoes, and he looked like a basketball referee. But I didn't ask him about that. I was asking about the studies. He said, yeah, I have schizophrenia. I've been to 4 studies of antipsychotics over the past 3 years, and they've all been great. It's been a really good experience. But there are a couple of things I can't help noticing about him. One is he's a very, very large guy. I mean, this guy is carrying a lot of weight. And 2, his mouth keeps twitching every few seconds. So if you know anything about antipsychotics, and I know some of you know a lot more than I do, you'll know what I'm talking about. Antipsychotics are not new drugs. They've been around since the 1950s. Thorazine was the first and most famous of them. Back in the day, they were called major tranquilizers. My dad, a family doctor, still calls them major tranquilizers. And in the old days, you would only give these drugs to patients who were really ill, because while they work in the short term, they dampen down the delusions and the hallucinations and so on. They also carry side effects. And the most notorious are the so-called extrapyramidal side effects, the dystonias, the dyskinesias, the writhing movements of the face and tongue, known as tardive dyskinesia. Let's just show you a few here. A lot of people have seen, you may have seen people with these side effects. A lot of people look at them and think it's part of the disease. But in fact, it's not the disease. This is the treatment for the disease, right? And the really dangerous thing about the extrapyramidals, or the really alarming thing about them, is that they don't necessarily go away when you stop taking the drug. So you can be left with these things permanently. So in the 1990s, drug companies started rolling out a new kind of drug, new and improved drugs, branded as second-generation antipsychotics, or so-called atypical antipsychotics. And the marketing pitch was no more extrapyramidal side effects, or much lower risk of these extrapyramidal side effects. And so doctors started writing prescriptions for antipsychotics for people who have never been given an antipsychotic in the old days, patients with insomnia, nursing home patients with agitation, anxiety, depression, bipolar disorder, PTSD, ADHD. And so by 2008, these drugs had become the single most profitable class of drugs in the country. More profitable than any other blockbusters out there. Fallen off a little bit since then, but they're still in the top 5. Problem is, it was all a con. And we know that not because the studies have shown it, especially the Katie study and the Cutlass study and a few other big ones, but because every major antipsychotic manufacturer has now had to pay massive fraud penalties. Zyprexa, Seroquel, Risperdal, Abilify, Geodon. Turns out that the atypicals not only still carry the risk of those extrapyramidal symptoms, they also make people balloon up in weight and increase their risk of diabetes. Drug companies knew this for years and they hid it. Now, that's not news. None of this is news. Or if it's news, it's old news. But what I'm going to tell you next is not well known, and I think it needs to be well known. And it's a little complicated, so I'm going to try to take it slow. So if you remember back to what I just said a few minutes ago, you remember that I said phase 1 studies are almost always done on healthy volunteers. Almost, not always, but almost. And there are a couple of reasons for this. One is a sort of common sense medical reason, and that is that these are safety studies. And it's a lot easier to tell if side effects are linked to a drug if the subject is healthy rather than sick, right? Because otherwise it could be what you're seeing is because of the illness. You give a sick patient a drug, they have a side effect, you don't know if it's caused by the illness, by another medication, by the drug itself. But if it's a healthy subject, pretty good bet that what you see when you give them the drug is a result of the drug. So that's the sort of common sense reason for doing these studies on healthy subjects. But the other reason is an ethical reason. And that is that these safety studies are almost pure risk, right? There is very little, if any, chance of therapeutic benefit in these studies. Remember, these are studies to determine safety, right? So if you recruit patients rather than healthy volunteers, you might well be paying them to stop taking a medication that's helping them and start taking another one just to see how toxic that other one is. And that seems wrong. And yet, that's exactly what's done in antipsychotic studies. Sponsors test these drugs on patients with schizophrenia. They do it despite the fact that these people may be too sick to understand the study, despite the fact that they may be living in shelters or recovery houses, and despite the fact that the drugs are unlikely to help them. There's one study that found that only 8% of central nervous system drugs that started phase 1 testing were eventually approved. So over 9 out of 10 of these drugs is never even going to make it onto the market. So why? Why use patients for these studies? Well, there's a cynical answer, and then there's the answer you get from researchers. And the answer you get from researchers is we test these drugs on patients with schizophrenia because they can tolerate the drugs better than people who are healthy, and they can tolerate much higher doses of the drug. That's the answer that researchers give you. Then there's the cynical answer, which is like the answer I got from Bob Helms, who is a former professional research subject who's done over 80 clinical trials and who won't do antipsychotic studies. And so people like Bob say the reason you got to recruit mentally ill subjects is that nobody else will go into these trials, that the drugs are just so unpleasant that ordinary healthy volunteers won't do them no matter how much money you pay them. Drugs are just too unpleasant. Now, I happen to think that Bob may well be right, but in fact, the issue is not just that the drugs are unpleasant, it's also that they're dangerous. That's what I want to talk about next. So a couple of years ago, I'm on my way to give a talk in Connecticut, and I decided to make a stopover in Willingboro, New Jersey, to visit a Phase 1 trial site by the name of CRI. This is what the site looks like online. This is what it actually looks like when you go there. I didn't have an invitation to visit. I just turned up and called from the lobby and asked if I could have a look around the unit, said I was curious. That doesn't usually work. It worked this time for some reason. I'm not sure why. So my tour guide was a psychiatrist by the name of Stephen Glass, who memorably was wearing this bright baby blue sport coat and a lanyard. That's the main thing I remember about the guy. He showed me around the unit. I have to say, it didn't look like the kind of place that would really give you the impression of clinical excellence. It kind of looked like it was furnished with furniture salvaged from the Salvation Army store. But that wasn't why I was there. The reason I was there was that I wanted to get a first-hand look at the place where a man named Walter Jordan had died. So who was Walter Jordan? Well, in February of 2007, he was a 47-year-old veteran. He was a widower whose wife had been dead for 6 years and the father of 3 kids. And he also had a diagnosis of paranoid schizophrenia. He heard voices that told him to hang himself, which he tried to do at least once. He had a cocaine addiction, he had a drinking problem, and he had an income of $845 a month in Social Security benefits. Spent a lot of time in the hospital, most recently after he had started to consider the idea of slitting his wrists. And after he was discharged, he was living in this lovely recovery house called New Desires. In April of 2007, he reported to a CRI unit to test the safety of a new antipsychotic, so new that it didn't have a name. It was called ASP-2314. I don't know how much he was being paid. If it was roughly similar to what other places in Philly are offering, it's probably around $2,000 to stay there for 3 to 4 weeks. Here's the name of the trial. Kind of complicated. As you can see, it's Phase 1 trial. And what they're doing is giving him an experimental antipsychotic and increasing the dose gradually to see what happens. And while they're doing that, they're watching his heart rate, they're watching his blood pressure, they're watching his heart rhythm, they're using an EKG machine, and he's wearing a Holter monitor so that researchers can get a 24-hour record of his what his heart's doing. So you might be thinking, why so much attention to the heart rather than the brain? I mean, isn't this an antipsychotic? Well, there's a reason for that. And the reason is because antipsychotics can cause heart arrhythmias, especially a very dangerous condition called torsade de pointe, which can lead to sudden death. And in 1996, an atypical called Certandol was submitted to the FDA and had to be withdrawn because of 12 unexplained deaths in clinical trials. Other antipsychotics have been given black box warnings for the same thing. So when you do these Phase 1 trials, you include all this heart monitoring to look for exactly this thing. So it's day 8 of the study. Jordan's wearing his Holter monitor, and about 10 o'clock he gets this sudden tightness in his chest. He's short of breath, his chest is tight, and he's sweating. The attendant calls Glass, the doctor, the PI of the study. Glass decides Jordan's having a panic attack, gives him Ativan, anxiety drug. Ativan doesn't help. An hour later, he's still in distress. He goes to the nursing station, tells them, I'm still in distress. Another doctor comes up, gives him a paper bag, says, try breathing slowly into the paper bag. He breathes slowly into the paper bag. It doesn't help. An hour later, he calls an attendant again. He's still in distress. They call Glass. Again, he decides more Ativan. Gives him a second dose of Ativan. Immediately, he starts to tremble and shake, and he falls backwards unconscious. They code him. They try to resuscitate him. But at 12:35, he's pronounced dead. According to an autopsy, cause of death was cardiac arrest. They never examined his heart, never did an EKG. Now, how do I know this? Well, that's a good question. Because when it comes to these studies in private trial sites, all this takes place in secret. Just try getting the information, and you'll see how secret. IRB proceedings, confidential. Name of the IRB, confidential. Consent form, confidential. If it's phase 1, in fact, the very existence of the trial is confidential because phase 1 studies don't have to be publicly registered. So unless you can get an informant, you can't see the protocol, you can't see the consent form, you can't see the payment schedule. It's as if the death never happened. Only reason I found out about this one was because a malpractice case wound up in federal court. And even then, the terms of the case were that, of the settlement, were that neither side could discuss the case with anybody else. Was it investigated by the FDA? No. Was Glass disciplined by the medical board or anyone else? No. Does the FDA think there's anything to worry about here? Well, that's a good question. So I called him up. Talked to Tom Loughran, who was at that point the head of the FDA CNS division, and Bob Temple, who's their resident clinical trials expert. Neither one of them seemed terribly concerned by what I was telling them. Yes, they knew phase 1 trials are done in patients. That's standard. Yes, they knew that some recruiters got subjects from homeless shelters. That's been going on since the 1990s. Is there any reason to worry about the competency of these subjects? Well, that's not for us to say. That's for the local IRB. Thanks very much for your time and conversation. So let me just try to finish by tying all this together and explain how things have gone so badly wrong. Now, I think for me, and I think for a lot of other people, you look at this group of people and think, if there was ever a vulnerable population, this is it. Destitute, mentally ill, African Americans living in homeless shelters. To me, that's about as bad as it gets. And yet, that's who we're recruiting to test these drugs. How's that happened? Well, it's complicated, of course, but I will just point out 3 things. One, we set up a human subject protection system in the 1970s that is almost wholly dependent on the honor and the good intentions of researchers. IRBs just trust researchers to do the right thing. Now, maybe that made sense in 1974. Kind of doubt it, but maybe it did. Definitely doesn't make sense now. You cannot police a global, multinational, multi-billion-dollar research industry with an honor code. It makes no sense at all, and it especially makes no sense when the police are getting paid by the companies they're supposed to be policing. The drug industry is now the leading defrauder of the federal government. Why should we simply just trust their researchers to do the right thing? So that's problem 1. Problem 2, there are no boots on the ground. What oversight we have is almost entirely a paper review. In other words, IRBs look almost entirely at what these companies write rather than what they actually do. I can remember the very first time I came across Guinea Pig Zero. This might be familiar to some of you. This is a job zine for professional research subjects that began in the 1990s. Now, remember, I was on 2 IRBs at the time, and it had never even occurred to me to think about the kinds of things that these guinea pig pros were writing about in this zine. Things like, are they going to pay you on time? Can the nurses hit a vein, or are they going to have to stick you again and again and again? Are they going to insist on giving you a rectal exam, whether the study requires it or not? And I thought, you know, I'm on this committee that's certifying these protocols as ethical, and I have no clue what's really going on out there in the trial sites. And the fact that we have no clue is the reason why we have had disasters like the SFBC scandal, which is a scandal where contract researchers in Miami were testing drugs on undocumented immigrants in a condemned motel for 10 years without anybody even noticing. How can that happen? How can you operate a trial site in a condemned motel for 10 years and nobody realize that? So that's problem 2. And the last problem I'd want to point out is with our ethical concepts. So if you look back at the big research scandals in the 60s and 70s, like Tuskegee, the common thread, I think, is exploitation. So with Tuskegee, it was exploitation of poor black men in Alabama. With Willowbrook, it was disabled, institutionalized children. With Holmesburg, it was prisoners. In every case, you have people in power taking advantage of a vulnerable person's circumstances in order to get them to do things that other people won't do. And yet, if you look at the common rule, the federal guidelines that govern research, you will not see any mention of the word exploitation. What you'll see instead is words like coercion and undue influence. If you look at any other major research ethics code, like the Declaration of Helsinki, you'll see the same thing. Now, it's not that concepts like coercion are irrelevant. There's obviously something there, but they just don't work very well for economic transactions. And that's what clinical research has become. It's a market. It's a series of economic transactions. And so when you talk about money changing hands, it's hard to make a phrase like coercion do much work for you. I mean, offering desperate people money to take risks to their health may be wrong, but how does that translate to coercion? I mean, it's not like you're threatening them, right? You're making them an offer. And so when you try to figure out what coercion actually means in this context, you come up with questions like, how much money counts as coercion? Is it the same amount of money for a homeless person as it is for a billionaire? If it's not, what limit should we set? I mean, you can see the kinds of issues that IRBs try to struggle with in trying to apply that. Now, I think exploitation better gets at the reality of the situation, which is that this is fundamentally a relationship, and it's a relationship between people who have power and money and status and people who don't. Parallel I'd make is sweatshop labor. So the issue with sweatshops is not that people are coerced into working there. It's that they're so desperate that they're willing to work there under horrific conditions for pennies. The issue is whether it's okay for us to take advantage of their desperation. That's what exploitation is. So let me just give you an example. Last year I talked my way into the day room at the Sunday Breakfast Mission on 13th Street. It was actually my first time there, and I have to say it was kind of a shock. I don't know if you've spent any time in shelters, but some of them are actually fairly upbeat sort of places in a weird way. There's a positive vibe there. There are people who are laughing and talking to one another. That's not the case here. I mean, as soon as I walked into the day room, I thought, oh man, I've never seen anything like this before. Everybody was sort of slumped over. They've got their heads down on the table. Everybody looks drugged or just bone tired. And you don't get this from the picture, but there's just this overpowering smell of urine and sweat and dirty clothes. And so I'm walking around, and I'm looking for people who've been in these studies, and I'm going from table to table, and then people start to call out to me. And they're calling out to me not because they want to talk to a professor or a reporter or anybody else. They're calling out because they think I'm a recruiter. They're asking me, please, can you please get me into a study? Now that is the essence of exploitation. These people are desperate to be exploited. Best explanation I heard came from the homeless vet that I mentioned earlier, the guy called Ed. He says, look, here's how it works. You're homeless, you spend your day chasing food. You're bullied by the police. They wouldn't even let you sit on a bench without harassing you. If you're a woman, it's even worse because you're forced to trade sex just to get a room in a boarding house. He says, this is what's driving people to places like CRI. It's one large nexus of psychological abuse. That was his phrase, one large nexus of psychological abuse. He says, look, you got homeless preying on homeless, you got police preying on homeless, now you got multi-billion-dollar corporations preying on homeless. The message is, guess what? It really sucks to be homeless. And I guess my question is, why do we allow this to happen? I don't have an answer for that. All right, I went longer than I thought, but let me thank you, and I hope we've got some time for questions.
Yes, to the extent that publicly traded corporations are the ultimate, folks who commission these studies, any thoughts as to whether shareholder advocacy can be a effective tool in dealing with this problem?
Maybe you could tell me. Quite honestly, I got a phone call from an attorney who works for a nonprofit, and I'm blanking on his name, who was asking me exactly the same thing. And he was a shareholder in, I think it was Johnson & Johnson, actually. And he was looking to try to get leverage for the same thing. It was completely new to me. I'd never thought of it before. But if you've got any ideas of how to make that work, that would be hugely helpful to me.
You uncovered and laid out a lot of obviously disturbing and chilling aspects of clinical research. It seems like the other risk that we're encountering now is the multinational aspect. And a lot of these trials are going, I don't know about antipsychotics per se,
Them too,
a ton
overseas.
of clinical trials going overseas where we have even less assurance or confidence in human subject protection. Do you have any comments on that?
Yeah, no, it's exactly, it's a market. It's cheaper over there. It's cheaper overseas. You have less oversight. The FDA is happy to take those studies. So, that's definitely an issue.
The Obama administration referred the Guatemala sex STD studies to the Presidential Commission for the Study of Bioethics for an assurance that our human subject protections, are adequate in the contemporary era. And, the political implication of that almost seemed to be an assurance to other countries that, if it's a U.S. company doing a drug trial there, you can rest assured we're all good. And I am not as confident as the President's Commission.
Yeah, I think part of the issue is that you have this sort of vast research ethics bureaucracy in place now, and a lot of people have a vested interest in keeping things the same rather than looking for any change. A lot of those people are academics, a lot of them are bioethicists, and I think, there are a lot of bad things going on in universities, in my university in particular. What's going on in my university is worse than I've seen in these shelters. But I think the dangerous thing about these private trial sites is that nobody is around. I mean, at least if it's happening in universities, I'll tell you what I was about to say. I was about to say, at least you have a bunch of people there who can see what's actually happening, who will hopefully blow the whistle. It doesn't happen that way. I've seen it in my own university. What you have is a lot of people who have a vested interest in keeping it quiet. But the thing out in these private trial sites is there's nobody anywhere around who ever sets foot in the place, and that I think is what allows abuses like this to happen. It's just that there are no police.
Is there anyone doing it the right way?
Probably, but what? Here's my concern. I've been in IRBs for a long time. I've been in 4 different IRBs, 2 at McGill, 1 in Minnesota, and the other one in South Africa. And at every place, I thought we were doing it right. Now I have no confidence that we're doing it right at all because I don't realize what was actually going on. I was on the IRB. I thought we were doing a really good job. We had some controversial studies, but some of them got through, some of them didn't. But I thought we were doing what we were supposed to do. Now I feel as if it's very possible that the wool was pulled over my eyes that entire time, and I just had no clue what was going on.
I think I'm the only psychiatrist here. Am I? Any other psychiatrist? What really caught my attention was how this is a part of a bigger problem in the field of psychiatry, and that the field of psychiatry is really focused now on drugs. And Mark and I worked very hard in the medical school when we first got there more than 10 years ago to get the drug reps out of our clinics. We were surprised by how much they had worked their way into being normal participants in what was happening in our clinics. And when we got rid of the drug reps in the clinic, there was a huge, huge pushback against us. I mean, it was really pretty ugly, you know, why? Because they would bring in free lunches and all sorts of stuff. The typical psychiatrist's world is seeing a patient every 10 minutes and writing a prescription, and then another patient comes in and writes a prescription. It is totally drug focused. But the best model for caring for individuals with schizophrenia is an entirely different model, and it's called Hospital Without Walls, or Programs of Assertive Community Treatment. And when I was an assistant professor, I got to be one of these doctors, and it was a team of the psychiatrists, nurses, social workers, and peers of individuals with severe mental illness, all doing the work out in the community, seeing these individuals every day. And what we saw was, when we saw them every day and made sure they took their medications, we were actually able to lower their doses of medications dramatically, and we were able to get them off many of their medications. Oftentimes we got medicine at a low dose. The other thing that we saw was, once they had stabilized and the brain had essentially had some time to be stable as well, after about 6 months there was dramatic improvements in the illness itself. Connected back with their families, able to go back to part-time work. It was impressive. And it's the gold model out there, but we're not training anybody to do that type of care. Instead, we're pushed toward this seeing a patient every 10 minutes or so. And the National Alliance for Mentally Ill has tried very hard to get this gold standard of care out there, but it's been very hard to push against the business of prescribing of drugs. Because, in fact, what we did was lower prescribing amounts, and we kept people out of the hospital. And that's not how the American healthcare system is designed.
Right.
Right.
Sure.
It's clear, though, that medications, there are drugs that have been very, very helpful, and research is doing so. How do you persuade a competent, well-informed person to be involved in a study that's going to hurt them? I mean, how do you get a subject where it really is fair?
I don't know.
Not doing human.
I mean, the question, I mean, this is always the question. It's like, well, nobody, like none of us are going to do these studies. You know, somebody's going to do them. Let's find people who are so desperate that we can persuade them to do it for our benefit. That is pretty much right there the definition of exploitation.
So what do we do?
Well, I don't have an answer to that. But I don't think that we can do it the way that we're doing now. We can't say to people who are so desperate that they have no other options, you have to do all these terrible things that we won't do ourselves. If we won't do it ourselves, then it shouldn't be done.
Well, if you started with your premise that this should only be done on healthy subjects, which is one of the sort of the phase one premise, then you could have market forces would jack up the price then, right? It would not be 2 or 3 or 4,000. It could be 30, 40, 50, 100,000, and that still raises ethical problems, sort of paying for people to harm themselves. But it seems like if you're starting with a healthy population, you might be creating more perfect. I mean, you have a very imperfect market here.
It would be better than what we have now, for sure. Now, this is one of the things that puzzled me when I started looking into this, because I looked at the market for phase one subjects, for healthy volunteers, and I'd been kind of surprised to find, I'm no longer surprised, but 10 years ago I was a little surprised to find that there was this sort of underground economy of people who would do this stuff for a living. Basically, that was their job, at least in their 20s and 30s before they started to age out. They would do this stuff, and they would make $20,000 a year doing drug studies for money. It seemed disturbing to me that these were almost all poor people, but I didn't have the same concerns that they didn't understand what they were getting into, at least as bad as I did here. Some of them, I think they're probably desperate enough, even if they're not mentally ill, that they would do anything for money. But you just got the exploitation problem, not the economic exploitation, not the mental illness problem. What really sort of set me off on this particular path was discovering that antipsychotics were tested on schizophrenic patients rather than healthy volunteers, and I could not figure that out because the only other area in which this is generally done is cancer studies. In cancer studies, you do the phase 1s on cancer patients, and that's just because you do it on patients who have exhausted every other option. So these are people who are probably going to die anyway, and then you say, will you do this safety study? And amazingly, some people will do it. And the reason you don't do those on healthy volunteers is because the treatment is so toxic you could kill them, right? You want to give a healthy person something that might kill them in a study. And so cancer patients, that's, with cancer drugs, that has been the standard for a while. But I didn't know about this. And so when, amazingly, the two guys that I showed you the video of, they're the ones who told me this. They're like, hey, maybe you can tell us this. Why are antipsychotics done on patients? It's not true in any other part of medicine. So I started calling up people and just asking. I don't know if you knew this. Almost no psychiatrists that I talked to are like, no, it can't be right. But when I started actually calling around to the trial sites, they all said, oh yeah, everybody does this. Every single trial site I called, or maybe half a dozen. And then when I called the FDA, they're like, oh yeah, we've been doing that for years. That's that's just the way it's done. But my question is, well, why? And the explanation I got was purely physiological. You got to do these things on patients that have been taking these drugs for years because they get very tolerant to it, and you have to raise the dose, much higher before you get to the maximal tolerated dose, and they start to seem toxic. Now, I couldn't understand the physiology behind that, but I especially couldn't mentally. But I especially couldn't understand the physiology of it on the heart, because I can't see why there's any reason why patients with schizophrenia would somehow be protected against the risk of sudden death in a way that healthy subjects wouldn't.
The only reason I think they tolerate higher doses oftentimes is because they have more severe illness. They are much more impaired than what I've seen sometimes.
Right.
Yeah.
The only other exception outside of cancer is dementia, because safety trials are done on demented people.
Are they?
Elderly, yes.
Okay. I didn't know. I know AIDS trials are sometimes done on sick patients, phase 1 AIDS drug trials. Okay, that's interesting to know.
Who signs for them?
Pardon?
Their family sign for them?
Mm-hmm.
Oklahoma allows the family. Oklahoma allows the family to sign on behalf of
in the hopes that they'll
in surgery.
become less demented?
Mm-hmm.
In research.
Okay.
We couldn't reverse the process if the process didn't exist.
Okay.
We're going to take a couple more and then wrap up.
Have you looked into the radiation studies? Because this theme of exploiting minorities and exploiting the illiterate, the economically deprived is continued through those. Law students can look up the case Henri Cincinnati radiation studies, and it's a motion for summary judgment that a very courageous federal district court judge denied, but involved the U.S. Department of Defense. But I wasn't sure if you were familiar with those studies as well.
Not as familiar, but yeah, I know them.
Well, this is the U.S. Department of Defense during the Cold War, testing civilians with it most of the time without their knowledge to see how much radiation they could absorb and how cognitively intact they remained as they died of radiation sickness. But the patients at the University of Cincinnati, another university teaching hospital, like Minnesota in your experience with the case that you described today, the patients had a variety of cancers, leukemia, some solid tumor cancers, and they were just dosing them as high as they could to see how they died of radiation sickness. Patients thought they were going through therapeutic treatment. They were not. Eventually, there were some informed consent documents signed toward the end of the study. One family described that the radiation dosage was so intense that when the family went in to see their loved one, they had to stand behind a lead shield in order to see the loved one. But it continues the theme that you brought up with Tuskegee and Willowbrook and that sort of thing. But this is fascinating. How did you actually get motivated to do such research in this area? Was it from the IRB work or?
Well, it started with Guinea Pig Zero.
Oh, okay,
Reading that zine back in
Okay.
in the 90s and thinking, a world that I don't know anything about. One person in the back and then more.
Out of curiosity, is this a global phenomenon where we test on those less fortunate, or is it constricted to the United States? Because you mentioned that there are other studies that we send across, but do other countries send their studies here for us to do?
Well, it depends on what you mean by sending them here. The major pharmaceutical companies are not all American. AstraZeneca is Swedish/British. GlaxoSmithKline is a British company. But they're all kind of global empires. And so they'll sponsor studies here for sure. With the antipsychotic trials, there seem to be a lot of Japanese companies, and they're doing trials here. But the general movement is to do the testing in places where it's less expensive. So poor neighborhoods in the States where people don't have any money or access to health care are a natural place. But the developing world is where it's all moving.
So, not thinking about phase 1 trials, but thinking about, drug efficacy trials, I wonder if you have any comments on the impact of, the expanded pool of generics and $4 formularies. When, recruiting indigent patients into a randomized clinical trial, one, it introduces a risk of therapeutic misconception, but if they see that as their only avenue possibly to get an active drug and to get some additional compensation when we have effective $4 medicines, that ideally we, have already been tested and proven to help their condition. So I know Scott Kim at Michigan has done some work looking at depression studies in particular.
And what has he found?
Just, highlighting the ethical challenges when we have these relatively inexpensive and proven efficacious medicines that it further exploits indigent patients, recruiting them into trials when they see that as their only way to get an active drug.
Yeah, that's exactly right. I mean, one of the things that Bob Helms, the Guinea Pig Zero guy, would say is, the irony here is that I'm never going to get access to these drugs when they're approved because I'm just not in the economic class to have health insurance. So I'm basically doing these studies so that the drugs will be provided to people who have money.
Well, on that note, thanks so much.